Welcome, everyone. Good morning. Bon dia. Guten Tag. Guten Abend. Welcome to the World Society of Pediatric Ophthalmology, webinar number 15 on allergic conjunctivitis. This is a global place for you to interchange ideas. A global discussion will ensue. You will be a part of it. Without your input, this doesn't count. The World Society is here because of you and for you. So, welcome to our speakers. Welcome to all of you around the globe. Wherever you are, go on YouTube, go on Facebook, and tell us where you are. Share with us. Share in that global discussion. Ask us questions. Those questions on YouTube, on Facebook, will be sent to us here for interaction. Anything that's not answered will be answered later in a PDF that is published on the WSPOS website. Today, we have for you something that is just incredible. We have ophthalmologists, pediatricians, allergists. We have put together an incredible world panel to discuss allergic conjunctivitis. In the future, we have multiple free webinars coming up for you to share in, for you to be a part of. This is to meet your needs, and these are free content. They will be found on YouTube afterwards. We want your questions. Please don't forget to bring them and bring. I'm going to keep saying that over and over. We're already seeing some people from around the world. We are seeing Canada, Mexico. I have to look down to see where everybody is from. The UK is here. Nigeria and Ghana are here. South Africa has joined us. Chile, Argentina, Singapore, Hong Kong, Australia, Germany, Denmark, Norway, Israel, Lebanon, Saudi Arabia. You are all in the house. Welcome. The USA is here. It goes on and on. New Zealand, welcome. And it just keeps going. We'll say hi to all of our friends as Indonesia, Malaysia. It keeps coming. Welcome to all of you. We'll keep answering your questions. We will be asking you questions on Mentimeter. If you go to menti.com and use the passcode 452800692, you will see our questions, 452800692. You will see them, and you can also use our QR code. That QR code will allow you to log into Menti, and you will see our questions that we'll be asking you, who you are, and what you would do in some circumstances for allergic conjunctivitis. Welcome to Egypt, Greece, Canada, Argentina, I think I mentioned already, Chile, and Brazil. Our friends in Brazil are here. Pakistan, India is here. We welcome all of you. We typically get about 100 countries or more that come through. Hi, Italy, as you join us as well. If you need a participation certificate, email program@wspos.org. And then let me introduce you to our first panelist. We'll go through all the introductions and then we'll begin our talks. Ophthalmologists may not know Bob Lanier from North Texas, where he is an immunologist. He's a professor at North Texas and a professor at Peking Medical College in Beijing. He's past president of the American College of Allergy, Asthma, and Immunology, and was its executive medical director for over 7 years. He's a former reporter here in the United States. He's done over 5,000 nationally syndicated pieces in radio and television. He's a communicator. He's a researcher with over 70 contributions in peer-reviewed journals. And Bob, I've known you for a long time, but I didn't know this, that you are considered one of the foremost international authorities on the genetics and mating habits of the northern raccoon. And you'll tell me how to pronounce that properly at some later point. And all of us will care because there's probably someone who's allergic to the northern raccoon. I'd like to introduce you next to my co-moderator, who has been a fabulous contributor to the World Society of Pediatric Ophthalmology and Strabismus. She is in private practice in Singapore. She's a past head of the Pediatric Ophthalmology and Strabismus group in Singapore. She trained in the United States and is one of the leading pediatric ophthalmologists in the world. And I will turn the program over to my colleague, co-moderator, and friend, Xiaowei Liu. Xiaowei, it's all yours.
Hi, hello everyone. So it gives me great pleasure to introduce Dr. David Granite, who actually doesn't need any more introduction. He is, as you know, the founding member of WSPOS, also the vice chair of the Department of Ophthalmology in UCSD, and he is just a very, very active person in all sense, yeah. So he's going to be the co-moderator. And the next speaker is Dr. Yair Morad from Israel, the professor of ophthalmology in Tel Aviv University. He is also the head of the Israel School of Orthodontics, and he's now a proud grandfather who has just returned from his vacation. Next up is my good friend, Dr. Dominique Bremont-Gignac from Paris. She's the Department of Ophthalmology at Necker Hospital. She's the professor and the head there. And I have had the privilege of visiting her in Paris, both at her department and at the Ophthalmology Rare Eye Disease Center. She's also the head of the orthoptic department at Paris University. We also have with us today pediatrician from Denmark, Dr. Elizabeth Cruz. She works with lots of children, and her expertise are in children with allergy. Last but not least, we also have Dr. Fernando Pucho. She's fellowship trained in the biggest pediatric hospital in Argentina. She is now in private practice in Cordoba in Argentina. So without further ado, I'm going to invite Dr. Pucho to start the first talk of the day about a case of keratoconjunctivitis conjunctivitis in children. It's VKC versus AKC. Dr. Pucho, please.
Hello, good morning. I'm honored with your invitation. I'm very grateful to WSPOS and to Dr. Nichel for giving me the opportunity of participating in this webinar. I will also like to thank my mentor, Dr. Apollo, who recommended me for this task. And today I want to show you a complex case, after which I will speak about vernal and atopic keratoconjunctivitis so we can discuss the differential diagnosis together. This is a 13-year-old male that was referred from Tucumán to immunosuppressive therapy. Tucumán is a city that is about 800 miles from Buenos Aires with a very dry and hot weather. He had a presumptive diagnosis of a severe allergic conjunctivitis, and he has been treated previously with triamcinolone that neither the kid nor his mother could tell us the way of administration, loteprednol in a very regular way, and all the anti-allergic drugs that existed in the market at the moment. When we met him, he was suffering from an intensive photophobia and blepharospasm. His visual acuity was count finger and 1/10. We couldn't take intraocular pressure or look at the fundoscopy because he couldn't open his eyes. We made an ultrasound that was normal, and we saw him through the slit lamp under general anesthesia. In the photos, you can see that in the right eye, he had giant papillae with a very adherent mucus and fibrin, and the cornea had a shield ulcer with corneal neovascularization. In the left eye, you can see that also have giant papillae and the shield ulcer and the leucoma and the vascularization, but the visual axis is respected. At that moment, we decided to start with cyclopentolate for the pain, topical cyclosporine 1%, artificial tears, and acetylcysteine with the intention of solving the mucus. We referred him for clinical examination, and the pediatrician diagnosed a generalized cirrhosis and erythematous and crusty plaques. Both findings could correspond to an atopic dermatitis. 1 week after, we add to the treatment supratarsal triamcinolone. The visual acuity at that moment was 2 lines. He returned to Tucumán and came back 1 month later. His visual acuity has improved 1 line in the right eye and 7 in the left, but he still was very symptomatic. He was wearing a baseball cap inside the room. So when we saw him at the slit lamp, the shield ulcer was bigger, the corneal neovascularization was worse, and in the left eye, the shield ulcer had fibrin on top. So we go to the OR and decide to make, in the right eye, an ulcer debridement. We administrate subconjunctival bevacizumab. We made an amniotic membrane implant, and we put triamcinolone again. In the left eye, we made an ulcer debridement. He went back home and returned 6 months later. We put the second dose of bevacizumab and supratarsal triamcinolone in both eyes. His best correct visual acuity was 1/10 and 9/10, but with a very high astigmatism. So we made a topography and a pachymetry, but the results weren't reliable because when we tried to repeat the study, they were different each time. We took into account because the frequent association between atopic and vernal keratoconjunctivitis and keratoconus. In this consultation, we add tacrolimus ointment to the treatment, and 3 days after, his visual acuity was 3/10 and 10/10. At the slit lamp, you can see that in the right eye, he still had the corneal lesion, but the visual axis is clearer, and the conjunctiva still have papillae, but they are less in number and smaller. The left eye, the cornea is transparent and is less hyperemic and with less mucus discharge. 8 months from the first consultation, 2 months of the treatment with tacrolimus and cyclosporine, his best correct visual acuity was 5/10 and 10/10. But the most important thing of this consultation is that he has improved his quality of life. He returned to his sport. He loves riding bike in the mountain, and he had returned to do that. This was his last consultation face-to-face pre-pandemic. He didn't return back, but he communicated with us by phone, and he told us that these years he was being diagnosed of asthma, rhinitis, and atopic dermatitis. So at this point, we wonder, it is a vernal or it is an atopic keratoconjunctivitis? It is important to differentiate them because they have different prognosis, different association, and different treatments in the long term. That's why I want to refresh you the pathology and the differences between them. The most important thing to remember is that there is no single clinical feature that you, in isolation, can differentiate between these two pathologies. The vernal keratoconjunctivitis occur more often in young people. They can or cannot have atopic dermatitis. Is more often in warm weather. There is non-specific hyperreactivity and non-specific stimuli. The symptoms are itching, redness, swelling, and discharge. They usually have photophobia, a giant papillae, punctate keratitis, shield ulcers. But referring to the treatment, this patient answered to a high dosage of cyclosporine and tacrolimus and usually end at adolescence. On the other hand, atopic dermatitis is more often in adults. It is the ocular manifestation of an atopic dermatitis, so the skin lesion must be present. Also, there is a non-specific hyperreactivity, and the symptoms in the skin of the periorbital are more relevant. So they usually have lid eczema, Denny-Morgan lines, madarosis, blepharitis, reactive ptosis. The symptoms are usually itching, tearing, and burning. Hyperemia, chemosis, chronic inflammation of the conjunctiva, keratinization of the eyelid margins, corneal ulcer, punctate keratitis, corneal neovascularization, and this patient answered to a low dosage of cyclosporine, and this pathology persists through life. I recommend this article to read, and it's very interesting. So, to the panel, what do you think about these patients? We think that it could be a vernal keratoconjunctivitis evolving to an atopic. Here is a little summary so you can discuss free. Thank you.
Great. That was fabulous, Fernanda. Can you stop sharing your screen so we can all come back onto together? And there's so much to unpack there. And as I do so, I just want to tell everybody that we have several other countries, including Russia, including Sweden and France have joined us. So Fernandez, that was fabulous. And I think that we ought to start with something as straightforward as this is a big deal. These allergic conjunctivitis affect a third of the population worldwide and are really important. Dominique, I saw your name on one of the papers at the very end that Fernando was quoting, and I was wondering if you wanted to say anything about this.
Well, your name was on also, so that's what a nice work together, and it's really to see that there is for sure AKC in children, and so we must know and we must be aware of it. And so thank you very much, Fernanda, because you put it that in practical, and so that's great.
Yeah, and you know, again, in talking about how important this is, I have scars. I don't know if anybody can see it, but I have scars on the top of both my corneas. If those scars had gone a little further, perhaps I would not be an ophthalmologist. So, and it tainted my entire childhood. I had to deal with eye problems. The one of the questions that I really been wanting to discuss during this session this goes to Elizabeth and Bob. We just heard an ophthalmologist present a case of allergic conjunctivitis, but should we be calling allergic rhinoconjunctivitis? I know you're both going to talk later. Was the treatment in that case, did it miss some things that we should have been doing as ophthalmologists because we didn't pay attention to the whole body? And Bob, you're muted if you want to try talking.
Well, I got first then, so I'll say yes. And I'll be talking a lot about that at the end of the day. That is actually my main topic. Yes.
So we can't forget that the eye is connected to the body, right? Exactly. Bob, you taught me that a generation ago.
Yeah, many years ago. Well, the problem is we haven't done a very good job with treating allergic conjunctivitis, and I'm really interested in see what Elizabeth says about this. But except for medications, I've been pretty impotent about the ability to manage early allergic conjunctivitis. And I was interested in seeing in that presentation the evolution of allergic rhinitis into another form. How well is that documented, and what is the mechanism of evolution for a totally different disease?
We don't know because this was this year in pandemic and he couldn't return to Buenos Aires because Argentina was in a very strict lockdown. So he communicated on phone and he told us that, and he has been treated, but the kid is 15 years old, so he couldn't tell us right.
Okay.
Bob, why wouldn't someone who has allergic rhinitis also have conjunctivitis? I mean, why would they not go together? In what circumstances would we think that you would only have one mucous membrane involved and not the other?
Well, I guess it's the density of mast cells, but there are quite a few people that don't seem to complain much of the eyes. I think you and I were working on some Alcon projects years ago, and we came up with the concept of if you don't ask, they don't tell. And so sometimes I don't get, a complaint. And then other times, horrendous complaints. So, as somebody that's looked at allergic rhinitis for like 50 years, I'm still confused about how the eye can be sort of isolated in some cases and so systemic in others. I'm going to bring that up when I do my presentation, because now we're looking at systemic therapies that really make a difference in other allergic disease, but actually may produce a disease as a portion.
I just would like to ask, in France, we say that when we have a questionnaire in allergy, we have to make this questionnaire like a police questionnaire. A police questionnaire, because we have to ask many, many questions to understand some mechanism sometimes.
Yes. Okay.
Are there any other questions or?
one of the audience, like in this case, was tacrolimus used for the skin?
Yes, in the eyelid.
The other question is, in these cases of severe VKC, when does, like, I like to ask the panel is from the audience as well, when do we use cyclopentolate in such cases? When would you use and when would you not use cyclopentolate?
We use with him for the pain just a few days and stop. But I don't know the other panelists.
Anyone else?
It's just to know if we use cyclopentolate to be sure of the refraction, or
cyclosporine or cyclopentolate?
Yes, that was a question. I did not get it.
They use cyclopentolate. I think it's for the ciliary spasm and all that, for the pain.
Okay.
Yeah,
okay.
But I think sometimes people worry about the corneal perforation. That's when they won't use cyclopentolate because they iris.
So I don't use that, but maybe some.
Well, I think that this case, and I'm going to discuss it in my presentation, is a classic case for systemic treatment with cyclosporine.
I think so.
These very severe cases react really good to systemic cyclosporine, and you can continue the treatment for years, like 2-3 years, if you monitor the renal function, the liver functions, and you get a very good response.
Yeah, ophthalmologists don't like giving systemic treatment, do we?
Yeah, we do that with rheumatologists. I never do that alone.
Yes.
That's why we refer it.
Yes. And this is a good moment for me just to remember to thank our hosts, Untitled, of course, and then Santon, who is sponsoring this session on allergic conjunctivitis, and has nothing to do with the educational content, but we do thank them for their support. Salway?
Yep. So I think there are lots of questions coming in about the therapeutic options, like how and when and how long do we use. So I would like to actually bring on our next speaker, Dr. Dominique Bremont, to talk about the therapeutic innovations for VKC before we go into the Q&A. Dominique, please.
Yes, I think this is a very, very good point to discuss. And so therapeutic innovation for VKC, we will see there is a lot, and I hope there will be more in the next future. So we know that allergic conjunctivitis is around 20% of the population. There was many studies for allergic studies in epidemiology, and up to 1 million children, 50 countries for the studies, and multiple clinical forms, mild to severe, and unhappily, this is vernal character conjunctivitis is very severe, usually. So we have the clinical sign itching, quite constant, mucus discharge, and some other less specific. And we know that VKC has two forms, tarsal form, limbal form, and mixed forms. And as I see all over the world, and we will discuss that probably after, is that the repartition between tarsal form, limbal form, and mixed form are different in different countries. So we have to release some symptoms that are really a problem for those children. And so we have classical therapies like lead hygiene, washing, UV protection, avoiding irritating factors, air conditioning, pollution, and lacrimal substitutes. We have also mast cell stabilizers, antihistamine. Sometimes desensitization is a very good option done by an allergist. And of course, the simplest is steroids. So we must be aware of it. So ocular washing, we know it's very simple, and I will not go over the treatments. We know also for the complication that we can just announce the healing for ulcer or vernal plaque with amniotic graft membranes, and we may be discussing this together after. So why do we need new therapies? Because we want to avoid steroid iatrogenicity. And we want to be efficacious, and we want to avoid these complications with blindness risk, glaucoma, cataract, herpes infections. So we need really steroid-sparing treatment. And we had that because we have topical calcineurin inhibitors with cyclosporine, tacrolimus. We have others, but they don't appear at the time as a good option because there is not many studies on it, and other mechanism. And I will let Yair discuss that because I'm sure he has a lot to tell about that. And these other mechanisms are very useful when we go for treatment additional to others calcineurin inhibitors. So cyclosporine, the mechanism is here with inhibition of a transcription factor, and it works on lymphocyte interleukin 2 and inhibition of T lymphocytes proliferation. What is original that there is a VECTI study that has been done, and this was really a randomized study, very interesting because it was quite the first time for it. And you have the publication here, and it involved 51 centers, 11 countries, with a multi-center randomized double mask, placebo-controlled, and 3 groups on 1 year follow-up with 169 patients. And during the 4 months of randomized patients, we had a significant improvement of SPK. I will not explain all the results, but it's really interesting. We have also topical tacrolimus and with ointment and suspension eye drops, as we have seen with Fernanda. And tacrolimus blocks activation of T lymphocytes and also inhibition of the production of inflammatory cytokines. There is topical tacrolimus in different studies, in different options about the 0%, the percentage. And so I will not detail, but we just published a meta-analysis of VKC medical treatments, and there is 45 studies that were analyzed and 27 randomized, 18 prospective studies, and 1,074, well, I mean, 749 patients were analyzed, and it was quite 80% of boys, 12 therapeutic classes, and for sure, there is 3 results very interesting is efficacy of mast cell stabilizer, probably not enough for severe cases, efficacy of cyclosporine and tacrolimus, and it does not appear with differences. And tacrolimus is really a good alternative to cyclosporine, but for sure, we need further studies for it. So if we go on the treatment options, I put in red what works, but that will be avoiding at the maximum, like topical steroid and steroid subtarsal injection. We see that we need to prescribe anti-allergic preservative-free, if possible, for antihistamine and mast cell stabilizer. And immunomodulators like cyclosporine and tacrolimus are really very interesting. And when there is a need of systemic treatment, we can have other medication or omalizumab, and I'm sure Yair will detail that much more than me. So just to look at VKC before and after cyclosporine, but you can see this child has eczema, so we may think, is it really a VKC or is it AKC? That's very important to think about that. So if we have a take-home message, I think earlier clinical diagnosis is very important to make the difference in the follow-up and the prognosis. Don't miss the small meaning like washing an environment. Don't miss also pediatric and allergic checkup because it's really needed. Choose steroid-sparing drugs like cyclosporine or tacrolimus if possible, and adaptive treatment improves really quality of life and avoid iatrogenic vision-threatening complication. So I just would like to thank my team in Necker in Paris. So thank you very much for listening.
Thank you, Dominique. I think we will go on to Yari Morat's talk about what to do when topical treatment fails. And then after that, we can have more questions on the therapeutic options.
That will be good.
Okay, do you hear me?
Yeah, Shaya, we hear you.
Mm-hmm.
As you're getting your slides ready, I just want to add that Estonia and Mongolia are also here now and have joined us as well. And we are now up to almost 100 countries that we have people listening from.
Okay, so my talk is going to be very practical, and after this talk, I guess you could get a good flow chart of how to treat these children that you often enter a clinic, rubbing their eyes, can't open their eyes in the morning. The parents usually ask you to shut the lights in the clinic also, because they can't even bear to sit in a room which is well lit. And the usual story is, doctor, we tried everything. We gave them all the anti-allergic medications, drops in the market. We used steroid drops. Sometimes it helps, sometimes it doesn't. But when we stop the drops, everything comes back. We gave them some oral medications, anti-allergic oral medications. We removed the carpet. We sent away the cat. But our child is still miserable. He can't open his eyes in the morning. He can't go to school, and he keeps rubbing his eyelids. And when you finally succeed in averting the eyelid, often you can't. Often the only way you can examine these children is under anesthesia. You get the picture of these huge giant papillae, which are really rubbing the cornea and creating all these symptoms. And at this point, you can start using topical treatment with cyclosporine and tacrolimus, and it will really take it, and it's really effective, but it will take the child weeks to get fully recovered, and you need a dramatic effect. So what do you do with these children? Well, one option is to use oral steroids. And this is very effective in the mild to moderate severe cases, if I can say so. And my choice is usually to use betamethasone soluble tablets, which are easily dissolved in water. You can give them to children 3 years old, 4 years old. You don't need to have them to swallow the tablet. And they have relatively good taste. And what I do is I give it twice a day for half a milligram for every 5 kilograms, twice a day for 7 to 8 days. And you usually get a dramatic relief. The child opens his eyes and it can function again. But you have to start the cyclosporine or tacrolimus together with the oral steroids. And by that, you hope that by the end of the treatment, the cyclosporine or tacrolimus will kick in, and it start to be effective enough that the child could go back to his normal life. So this is one option. But and actually, for older children, you can also use oral prednisone, 10 to 20 milligrams per day for 7 to 10 days. But for the severe cases, those with the huge giant papillae, the severe photophobia with the shield ulcer, there is, in my opinion, only one solution, and that is a supratarsal injection of steroids. And this was first reported by Holzklow at 1996. He reported 12 patients with resistant vertical keratoconjunctivitis. And this is what he did. He flipped the eyelid, and the injection site is just above the tarsus here. And I'll show you a video in a minute. And in his series, all patients had a dramatic relief within 1 to 5 days. All shield ulcers resolved. That's the optimum side. On the negative side, 2 patients needed repeated injections every 2 months, and 1 patient had a persistent Iop elevation. And Iop elevation is really a concern. We'll discuss this in a minute. So how do I use how do I treat these children? I usually use a combination of triamcinolone, Kenalog, with dexamethasone in 1 cc insulin syringe. And in my opinion, this helps, this combination of short-acting and long-acting steroids help avoiding the IOP rise. And what I also do is I put the child under general anesthesia and I inject a combination of lidocaine marcaine solution subcutaneously in the upper eyelids. And this is very important, but otherwise when they wake up, they have a severe pain and you'll hear them screaming in the recovery room. So it's very important to give that before you inject the steroids. And I found a video from India. I didn't have one for myself. So thank you, Dr. Priva Desai from India, for putting this film on YouTube. So you see how you inject the needle, the steroids, and you balloon the conjunctiva. You see the balloon of the conjunctiva in the upper eyelid, and it's really easy, and it's like a few seconds, and that's it. And you get a dramatic relief. This is really, I think this is one of the most amazing procedures you can do in ophthalmology. One day you have this child that can't open his eye. The next day he's smiling, the eyes are white, the conjunctiva is white, and the parents are really thankful. And this is another picture. This is before treatment. This is 3 days after the injection. The child goes back to life. But at this point, the danger is being too optimistic. You can't stop treatment. You have to start topical cyclosporine 1% or topical tacrolimus. I use usually 0.6% immediately. Otherwise, the disease will recur within 2 to 6 months. And what about Iop elevation? Well, what I usually do is check the Iop after 1 week and after 1 month. And with this combination of short-acting and long-acting steroids, I had 0 cases of Iop elevation in 12 years. It doesn't mean I won't have one, but it's really, it's not an issue for me anymore. And for the really severe cases, when the disease recurred shortly after the injection, or when the topical cyclosporine or tacrolimus are not tolerated by the child, that has a stinging sensation that they just don't get the drops. I had only 6 cases like that in 15 years, so it's really rare. First of all, you have to make sure that there's good compliance. Sometimes the parents just don't tell you that they don't give the drops. So if you are sure that the compliance is good, in my opinion, the next step is systemic cyclosporine. And there are a few reports about systemic cyclosporine in adults with vernal conjunctivitis, and none of them had any report of side effects, and all of them had very good response to the treatment. In our institution, we treated 6 children in the last 15 years with systemic cyclosporine. Ages were between 4 to 15, all were males. All were treated previously with cyclosporine and tacrolimus drops. In 5 cases, the disease was just not well controlled by the drops, and one child, and this was the 15-year-old, just refused to take the topical treatment. And since it's a 15-year-old child, you can't just hold him and give him the drops, so I had to switch to cyclosporine. Before using the cyclosporine, just to show how severe these cases were, one child had steroid-induced glaucoma that necessitated Ahmed valve implant. Another child developed shield alpha that necessitated corneal transplant. So these are really severe cases. And how do we treat? The dose we use is 3 milligrams up to 5 milligrams per kilo per day. We closely monitor the renal and liver function, and also the cyclosporine blood levels. Sometimes we add topical treatment with anti-allergic medication like azelastine, or even topical tacrolimus. And the duration of treatment is usually a minimum of 1 year, and in several cases even more. One of the cases we treated for 3 consecutive years. In all cases, it resulted in total remission of the children. They went back to normal life. If you ask about side effects, one child developed duodenal ulcer after 3 years of treatment. We're not sure it's related to the cyclosporine. We switched to topical treatment and treated ulcer, and he was recovered completely. Another option is to use systemic tacrolimus. This is another option that you can use. There are few reports about adults with systemic tacrolimus in the literature. In all cases, there was very good response, but they had some neurological side effects, paresthesias, muscle cramps, memory difficulties. They achieved remission, and all of them chose to continue treatment despite the side effects. But we don't use tacrolimus because of that, because we're really happy with the treatment with cyclosporine. So my flow chart for the severe cases is this. First of all, you inject the supratarsal steroids. That will bring the disease level down, and the child will be back in normal life. And then you have to continue with topical cyclosporine or tacrolimus. If there is a recurrence in less than a year, check compliance. And if you're sure the compliance is good, you go to systemic cyclosporine. What about surgical removal of the papillae? Well, I think it is never needed. It creates unnecessary scarring, and the steroid injection will have the same effect. So in conclusion, systemic steroids can provide fast relief in severe cases of VKC. Supratarsal injection will bring the child immediately back to normal life, but you have to keep treating with topical treatment. Systemic cyclosporine is safe and highly effective method of treatment in severe cases. Thank you.
Okay, thank you.
Fabulous, Yair.
Yeah, so I think we've got a lot of questions coming in. Before we start the rest of the questions, I would like to ask Fernanda, because there are some questions still about the case, a very interesting case. What was your dosage of subconjunctival bevacizumab, and did you use steroids as well?
The subconjunctival bevacizumab, we use 2.5 milligrams in 0.2 milliliters.
Okay. And
topical steroid, no, because he was using long time, and it was very difficult to us to take intraocular pressure, and we are using triamcinolone, so no more steroids.
Okay.
Yair, have you injected bevacizumab?
No, I never had a case of neovascularization. Well, we managed to avoid that.
And that was one of the questions that came up online, which is, are there side effects of long-term topical use of cyclosporine?
Well, this is a question that I get repeatedly. Cyclosporine, if you examine the blood levels of cyclosporine when you use it topically, you can't even measure it, and it also does. It's not entering the eye. It stays only on the conjunctiva. So there's zero side effects. I have patients who had cyclosporine for 7 or 8 years and zero side effects. Also, with tacrolimus, there's this black box warning about some kind of risk of cancer, what patients are really terrified about. I don't think it's related to topical use in ophthalmology.
So for topical cyclosporine, it's only local topical problems, and mostly it depends also on the formulation. So that's very important to know what is the formulation. That was when there is a cationic emulsion, it's easy to be tolerated, and also for tacrolimus there is still not ongoing thinking that there is any problem of dermatologic problems, and really we had the dosage also of cyclosporine when it was topical instilled, and there is it's so negligible in the blood, so there is no possibility of other adverse event on it.
Dominique, we've heard a lot about the use of steroids, right? We heard about oral steroids. We've heard about topical steroids, but you were looking in your presentation, you talked a lot about steroid sparing medications to avoid the steroids. We have a pediatrician and an allergist with us. They take care of a ton of allergy. Should allergists and pediatricians be using steroids? Dominique?
Well, I think that they refer patients to ophthalmologists, but of course, when there is an allergy, they use steroids. So if we just add topical steroids and if it's just punctual, there is no problem. But if we do it again and again, that's a big problem. That's why I was telling about steroid sparing possibilities. And I really think that we have seen sometimes, not very frequent in France, not very common, but we have seen really very bad complication with a long-term steroid treatment. So we must be aware of it because it's so easy to treat this way. And also because the parents, they go and tell and go to see different ophthalmologists. So the ophthalmologists that do not know, because they don't know that the child has another treatment somewhere else. So that's why it's a big problem.
And do we have to worry if allergists are treating rhinitis with nasal steroids chronically? Do we have to worry about intraocular pressure?
Elizabeth, I think
there's actually been quite a lot of studies in that field, and there's actually there's no risk for ocular pressure by the nasal steroids. It's such a low dose you get systemically. So no, I would say no. But I have had patients with glaucoma or with severe family history of glaucoma, where I asked them to see their ophthalmologist, so that when I start this treatment, they have a closer follow-up at the ophthalmologist. Yes.
Yeah, so you can see the overlap between our different specialties, and that we've now heard 3 ophthalmologists speak about treating an end organ, the end of the long chain of allergy, and I didn't hear anybody talk about a workup. As people who deal with allergy, Bob and Elizabeth, should ophthalmologists, is there a workup we should be doing? Should we remember this as the end organ?
I said that. That's important, because I told that it was important to have a workup in the last slide. So I'm very happy you are here to talk about that.
Yes, I know we know to throw away the cat. Yeah, you're mentioned to get rid of the cat, but what should ophthalmologists be doing? Bob?
Oh, you mean when children have allergic problems?
Yeah, when we see somebody as an ophthalmologist with bad allergy, ocular allergy, we don't ever ask the other questions, right? We don't ever ask about asthma, right? Yeah. So we're ophthalmologists. We're looking at an end organ.
Well, I think my ophthalmologists are the ones that I work with, make the suggestion back to the primary care. But we have a little bit different system here where the primary care physician is the one that sort of makes the referrals. And primary care in the United States has part of its training to deal with working up allergy. So the referral to a specialist is a matter of degree and what the awareness is of the family physician. So we would see just a small number of people who have allergy because the myth still exists that you might outgrow it, which is archaic but still there. So we take anything we can get, but it's rare to us to get a referral from ophthalmology.
Elizabeth, any other?
Well, I think it's really sad that you don't look at the child. Sometimes they have eczema all over the body. They have sneezing. They have lines showing over their nose. If they have a family with a lot of allergies, I actually think you should be aware of that too. And sometimes in Denmark, the families go straight to the ophthalmologist. They are not referred by the private practitioner. So it's important. And I do get referrals from the ophthalmologist at the hospital regularly. So we work together on these patients.
Yes.
Yes.
I was exaggerating to
get curious, and then say, I don't want you to start treating the asthma and so on, but I just want you to get curious and refer them.
Yes,
that's
but
great.
the question is, what is the, if you want to do it practical, if you identify the exact allergen, what's next? This, I'm asking you.
You're asking me? Good.
Yeah.
So the exact allergy, like say the cats or birds, or what do you
Yeah,
mean?
of course, you can take away the cat. Okay, but if it's like
But
pollens
desensitization.
or something like that.
Yeah,
Well,
desensitization.
immunotherapy is actually a really good idea. And often these people also have asthma. Quite often they also have daily life problems that you as an ophthalmologist actually do not really take care of. so sometimes, especially with the pediatric group of patients, they should see a pediatrician. Yes.
Yeah, and there was an allergist named George Bench that I was at a meeting actually with Dr. Bob, who was the first person I ever heard talking about washing your hair before you go to sleep.
Yeah, I'll be talking about that too in a minute. Yes.
Yeah, and so
exactly.
and actually about replacing your pillow, because I found out at allergy meetings, pillows are after a few years are no longer made of what you think they're made of. So there are some very simple that Dominique and Yair and Fernanda mentioned in terms of changing carpet and getting rid of the cat, that I think ophthalmologists need to know about. Even rubbing the eyes. I remember my dad grabbing my arm and pulling it away, not to rub my eyes as a kid because of my vernal keratoconjunctivitis. All right, before we get too far out of our schedule, Dr. Bob Lanier is the next up, and he'll be sharing his slides with us and teaching us a little bit more about allergy and about the eyes.
Now, David, since I didn't attend the earlier thing, how do I share the slides?
On the bottom of your Zoom screen is a little button that says Share Screen. It's green in color, and it should be on the window of your Zoom screen.
Share screen.
On the bottom of the Zoom screen,
okay,
you'll see participants, chat, and share screen.
Got it. Okay, so that will.
Yes, and then if you go to your first slide and hit play slide presentation just the way you would, you are on, and you are live.
Okay. They say that not being able to read a clock is the first sign of inability or Alzheimer's. And from that description, I certainly meant it, since I missed a couple of the meetings that would told me how to do this. So I apologize to the audience. My name is Bob Lanier. I'm an allergist, a pediatric allergist, and a pharmaceutical researcher and a clinician in Texas. And what I'm going to do for you is differ a little bit, because I'm going to go through some historical concepts here. And I'm going to show you how allergists have sort of made a conversion from looking at the nose to looking at skin, how they've made an alteration from medications to cell structures, and from cells to chemokines and interleukins. And then back to the red eye, because we are now creating it sometimes in the process of trying to clear other diseases. So a base timeline for this is that first skin test apparently done formally in 1878. The first allergy shots done in 1911, which was an attempt to give people the hair of the dog that bit them. A very controversial effort, which even during World War I and the Spanish epidemics of flu that came about, it became a national and an international, a world global standard format of allergy from about 1914 until 1955 in this country. And the only reason it maybe lessened a little bit in the 50s here is that we began to see medications being pumped out of Europe that had been previously discovered but not yet administered in the United States. So I'll remind you, 1937 was the first mediator antagonist developed in France and Belgium, and initially used to quiet down combative prisoners in French prisons, because it makes you pretty loopy. Never got much traction there because the doses had to be changed so much, but always remember the reason that some all psychogenic agents have a piece of the molecule of antihistamines is because they are indeed psychotropic. Then as later came on, by the way, this this never really made a lot of difference in the eye to me. I'm an allergist. I think I have had some success with immunotherapy as far as my production of eyes, but I've really depended much of that. I'm interested in listening to you, Liz. I've depended mostly on medications while I do immunotherapy for certain. Medications have been a big gulp for me, and not so much immunotherapy. So after that came, of course, all the mediators and the antihistamines, antileukotrienes, mast-cell inhibitors, all the things that we've been used to going through for allergic conjunctivitis. But there's been no real advance in direct treatment of eyes inside allergy for a long time. Now, that may have changed a little bit in 1970 when the Ishizakas in Denver, Colorado, and Johansson in Sweden first conjointly discovered or announced the discovery of the fifth antibody, which was IgE. And that antibody at that point explained why the histamine release occurred with allergy and brought it up as a genetic defense mechanism. We think a consensus of a feeling is now that that the allergic antibody is a defense role, but its defense has long since been poorly needed. The defense for the allergic antibody, of course, is a parasite, and most commonly the helminth parasites. If you have a really good IgE defense and are exposed to parasites, especially helminths, well, you got a real good chance of survival. So the allergic antibody itself was a survival passport for humanity from time began up until maybe 1200 AC, because the antibody was necessary, and people could mount a good response, detected it, and defeated it. People who didn't have that response and got exposed just died. The advantages were significant, and then as people began to do more reasonable things like wear shoes, began to cook food, began to develop some sort of latrine system, then the need for this antibody system has waned on a daily basis. None of us really need this. We don't come across parasites very often, or at least I don't in an industrialized country. I see it in missionaries, and I see it in medical troops, but rarely do I see it for domestic people that are born here. Of course, in third world countries, it's still not uncommon to see parasites. And so the utility of this antibody still has purpose in some parts of the earth, but the rest of them, no. And we think what happens right now is that the allergic antibody and that ability to use it is transferred over into normal people in an industrialized country as an enthusiastic antibody system with no use. Unfortunately, especially in small children, as they get the kind of infections that require an antibody response, and the E-class antibody comes out along with everything else trying to find something to fight, it may make some basic errors about what is good and what is bad. And apparently there is a close relationship of some of the proteins arranging that allergy is a case of mistaken identity in people with a superior immune system. Now, everybody in the world, or almost everybody in the United States, believes that they have allergy. It's 95%. When in truth, the percentage, and most of the time, if we really try to academically pin it, is something like 18%. There's also a myth that you outgrow allergy. You do not, but you have periods of exacerbation and remission. So against that background, allergy doesn't seem to be a very big complaint in our country because of the myth of potentially outgrowing it, and because of being a small problem in the general population. So while we knew a lot about it, we didn't have much to do with it until a fellow named Sewin Chain changed that. Now, our intensity became looking at cells, and particularly the mast cells and the little receptors that mast cells had for pollen or other protein. And the receptors being close together, if they were bridged by protein, then that would cause the mast cell to degranulate and lose the histamine. So for much of the time that we've been working, whether it's been with drugs or then again with the potential for antibodies, has been this fixation on this portion of a cell and indeed the receptor of the cell. The first person to make something out of this was a fellow named Se-Win Chang, who at the time was in Houston, Texas, and now is back in Taiwan, who discovered the ability to be able to make an antibody to the allergic antibody. And the allergic antibody would then tie up the receptors, which would allow, theoretically keep cells from exploding and therefore solve all allergy. Well, it didn't work out that way. I mean, this anti-allergic antibody was called Xolair. And for some people with allergic asthma, it's been pretty good. But we've never noticed much improvement, or at least I certainly haven't, with respect to allergy. And one of the reasons is it's very expensive and it's not used. And I think that it's just not been well studied. But despite its potential, problems such as allergic rhinoconjunctivitis is not been outstanding. Let's say that. So I have a lot of people on this particular medication because I'm primarily a research biologist and respiratory disease and mostly asthma. I've made extensive surveys through the years on everybody I put on Xolair, which is now over 500, and just haven't seen anything that I was really impressed with, in particular in reference to the expense of the medication and its availability. So,
Bob, I'm sorry to interrupt, Bobby. I'm sorry to interrupt you, but you're well over. Can you wrap up in the next minute or so?
Okay, yes, I will. I'm so sorry. Let me, all right. So the thinking now has been about cells. In this case, what's noted is the eosinophil. And if you look at pictures of fires and you see the same person in the background all the time, you begin to think that person has some problems. That is the issue. And indeed, it has been. We've looked at now eosinophils more than we have any other cell. And what we found when we use anti-eosinophilic drugs is that we can decrease them quite a bit with both of the newer medications, but they don't have any effect on the eyes. Nobody's claimed that these anti-eosinophilic drugs make much difference. So what we've been looking at it now is a different thing, and the one is called Dupixent. It's an IL-4, IL-13, and it increases eosinophilia rather than reduce it. And it's been just a miracle about how it responds. You can tell before and after in a relatively short period of time. I mean, I tried it. Look what it did for me. But the problem that came up is this. We see this not uncommonly, this conjunctivitis. And I went back to one of Abelson's slides way back in the 70s, and we looked at the blood eosinophilia in association with different diseases. And you can tell with seasonal allergic rhinitis that it's just not very much there to associate it with. And the other diseases that have been talked about this morning have a higher level of blood eosinophilia. So we think that the causation of this is interference with goblet cells referenced by IL-4 and IL-13. And we see a goblet cell. And so issue. So this has made a big change in practice for allergists in this country, at least. I am, because of this problem is common in the general literature says 10%. Our experience in people who have bad AD is closer to 20 or 25%. The change in practice for me has been to add an ophthalmologist in the very first consideration period. I want baselines on everybody that does Dupixent. It's a small charge, and in addition to because of the wealth of the basic problem. So I want to thank the WSPOS and Santon, and just raise the idea of if anybody's dealt with this very much, and what your thoughts are on it.
Okay, thank you very much, Dr. Lanier. I think we could move on to Dr. Elizabeth Cruz for the final talk before we go on to the Q&A. Dr. Cruz, please. Elizabeth, can you unmute yourself, please?
Sorry, try again.
Yeah.
Perfect. As I was trying to say, I will do my very best to talk about everything but the eye today. And I would like you to know one of my patients. His name is Marcus, and he's 12 years old. Marcus has quite a lot of diseases. He has morbus Hirschsprung. He has gluten intolerance, the real one, not the one where you claim you have gluten intolerant. So he has a lot of abdominal problems. He has a lot of pain. He has a lot of discomfort during his days. He has asthma, severe asthma. He takes medication morning and evening, and sometimes when he has exacerbations as well. He has atopic dermatitis. He needs to cream his body. He has scratching skin. He has night sleeping problems. And he has allergic rhinoconjunctivitis. And one day he was visiting me in my clinic, and his mother was speaking to me while Marcus was doing the spirometry exercise. And she was telling me, we can deal with all these diseases. We can deal with the stomach problems. We can deal with the diets. We can deal with the creams. We can deal with the medication. But his hay fever is taking the joy out of his life. The hay fever is making it impossible for him to attend school, to follow his friends to sports, and so on. So hay fever is actually a massive problem, and it's often put down. I often hear my friends and colleagues say, okay, now it's changed and now it doesn't. Okay. I often hear my colleagues say, it's only hay fever. He only has hay fever. And it frustrates me massively, because it is actually a disease that has a very big impact on quality of life. It results in loss of productivity at school and at work. It increases numbers of sick days in the patients. It lowers their ability to learn and remember. And they have actually a higher frequency of depression compared to the rest of us. Marcus, at this time when his mother was talking to him, was quite heavily medicated. He was receiving intranasal glucocorticosteroids combined with antihistamine. He was on oral antihistamine, sometimes double dose. He was taking antihistamine eye drops. He was on montelukast, also called leukotriene receptor antagonist. And he even had periods where I had a helping hand from an ophthalmologist treating him with ophthalmic corticosteroids. His symptoms from the eyes was itching and burning. They were watery, and he had the dark coloration under his eyes. It's known as shine, allergic shine. He had conjunctival injection in his nose. His nose was blocked, but it was also watery, and he was sneezing, and it was itching, and he had a sore throat due to what we call a postnasal drip. Basically, it drips back instead of front, the water, and it annoys his throat, and he gets it soring and itching. But the biggest problem for Marcus in all of this was his fatigue. He did not feel well. He felt like he had the flu. He felt like he had a fever, basically. You must also remember, I want you to remember, it is actually quite important for children to be able to close their mouth. When you cannot close your mouth, when you are mouth breathing all the time, you have an extreme high tendency of getting dental caries, because you do not get saliva in your teeth. You do not get protection than the rest of us get. But for a child, if you cannot close your mouth, you cannot get a correct development of the facial bone. You get an inadequate facial development. You actually get structural malformations of your face, basically, if you cannot close your mouth when you're a child. And that results in dental malocclusion. If you want to read more about it, I have actually referred here to a very nice study who also shows some very nice pictures. So, Marcus, what can we do? Allergen removal, medication, and allergen immunotherapy. And as for the allergen removal, well, when it comes to pollen, basically, don't take it with you to bed. Wash your hair before you go to bed, okay? Don't hang your clothes outside to dry. It's no need to cover it in pollen. And when you have to air out your house, do it in the early morning and late evening when the dewdrops are holding down the pollen. As for the fur animals, I can speak for hours about this. So if you want to hear more, just tell me. But anyway, try to remove those animals from the patient's environment. Sometimes it's not possible. And as for the house dust mites, air out your house regularly. Keep the humidity down. That's the key point here. And boil wash your bed linen. Make sure it's warm enough when you wash it. That's the main clues. And don't forget nasal saline irrigation. It actually works. It's actually a very good help. What more can we do for Marcus now? Should I give him an adipoid steroid injection? I'm not pro, I don't like it. And if you want to read more about it, 2 articles downstairs here will tell you why I do not like steroid for children in that amount. But I might have to give him some oral corticosteroids for a very short period of time, only maybe 3 days, 4 days, so that the overall allergic reaction in his body will come down and allow the other medication to come in and actually take on the role they should have. But when you do systemic corticosteroid in a child or anybody, plan for the future. Don't end in the same situation again next year. Make sure that you have seen this coming again in 12 months, okay? So allergen immunotherapy, I'm absolutely for this. I'm very fond of it. And Marcus also went through allergen immunotherapy for grass and for dust mites, and he's actually massively improved. He does not become medicine free. That is not the goal of immunotherapy. The goal is to become manageable, really, in daily life. Okay, there's a lot of documentation telling us that allergen immunotherapy works. It works in the management of allergic rhinoconjunctivitis, and that's the subject of us today. I know I put the rhino on it because it's very often, the way I see it, it's combined, the two of them. It is good in the management of allergic asthma. It's good in the treatment of allergy for insects, for bee and wasp. It gives a significant higher quality of life score in those who have been through allergy immunotherapy. It results in less medication for asthma and rhinoconjunctivitis, but not necessarily no medication. And it's protective against the development of new allergies in monosensitized patients. It's protective against the development of asthma in patients with allergic rhinoconjunctivitis, and sometimes it also takes away the symptoms of cross allergy in birch and grass pollen patients, but that is no guarantee. So basically, allergic conjunctivitis often requires more than local treatment. Remember international glucocorticoids, and please start before the season so that they can actually get primed before the pollen starts hitting them if it is a seasonal allergy. If possible, do allergen removal. And if you have to give systemic corticosteroid, plan for next season. Don't end there again. And remember allergen immunotherapy, please refer them to us. We would like to help you. That was my talk for today.
Thank you. That was spectacular. So let's talk about what both you and Bob have just raised. First, I want to re-emphasize rhinoconjunctivitis. I love the word, and it reminds all of us about the connection back to the eye. Bob, a bunch of things came up online when you were talking. I just want to share with you. One is that other people have seen the Duplicent eye changes, and it's already been proposed online through our discussion groups. Maybe we need an international collection of data and put that all together. So I thought that was the World Society at its best with people, and I'll connect you to those people after we're all done, so that you know. Additionally, other people noted that here in the United States, we do see parasites because of health inequities, and that there are people living in areas that they're saying they're seeing. In fact, one person who moved here from the UK said until he got here, and he lives in a city, I won't say which one, he hadn't seen parasite disease to the same amount. So the other tip, I loved it before the season starts. So the online, the discussion has blown up, and I think it's so important for us to have heard your approaches to all of this. So as someone who's a dog fan, I got it now. We throw the cat out. That was the big other takeaway, right? Yes. Fernanda, is it do you see the immunotherapy in South America the same way that Lisbeth and Bob spoke about?
Yes, and my child is using. Yes. The results are amazing. Well, my child, he has rhinitis, and with the immunotherapy, he's very well now. He now is 5 years old, so the symptoms is better. But with my patient, I have only one that is using immunotherapy, and the symptoms has improved.
David, so we have multiple thousands of people online. Bob, go for it. What were you going to say?
Okay, one thing I didn't see mentioned is that that antihistamines are still the foundational support for allergic rhinoconjunctivitis. And when we study antihistamines, as I did when I helped with the registration trials with at least 6 of the brands, we would do dose ranging trials from, say, 100 milligrams down to 5 milligrams. And the dose that was chosen was company chosen because of marketing considerations. In other words, you're not going to put an antihistamine out on the market that makes you sleepy. That niche has already occurred. So most of the arguments come down to the lower doses. So in many cases, the doses chosen that will get the least sedation and the most benefit. Some medications like loratadine were reduced so low that there's just not much antihistamine to use. Some of the others, like cetirizine, have a much higher sedation rate, 12-15%, but even that's not necessarily the limit to use. We've studied drugs like that up to 50-60 milligrams, and it's one of the things that we do is always dose escalate with antihistamines in order to try to find what the level of antihistamine would be to match the amount of histamine that the person is releasing, knowing that's a preventive drug, it must be taken before. And on many occasions, you'll see that 1 to 1.5, sometimes 2 times the marketed dose will effectively manage this. Now, the problem in doing that is that as you increase the antihistamines, you may affect the eyes as far as drying them out. So there's always a kind of a yin-yang about how much can you get away with to help the nose without producing issues for the eyes.
Well, as a pediatrician with many different kind of allergic patients, I also treat those with chronic urticaria, and part of the treatment there is actually to go up to 4 times recommended daily dose in antihistamine. So I don't see them get very tired. I don't see my patient get a lot of eye symptoms doing this. And if they tell me this kind of antihistamine makes me tired, we try another one, basically. Yeah. So yeah, I try start with the cheap one and move on from there.
Well, it's still the molecule of active antihistamine that makes the difference. Yes. And there's really not much difference between branding because they're all preventative. But the idea of fatigue is subjective. And so when people look at the studies, what they do is they market the level that gives the least on those particular things. But as you mentioned, when we deal with hives and other problems, you sometimes go up to 4 times the dose and get away with it well. But I have had some people with significant conjunctivitis who will get a little drier, even though the cholinergic effects of the newer antihistamines are not as bad as they might. But it's one of the reasons that we look and say, if we need to do allergy vaccination, it's because the burden of medication is so significant that you warrant going outside the box to do a long-term commitment of high logistics and sometimes high expense with immunization.
Dominique, when we give medicine, we drip it right on the organ we care about. Our pediatricians and allergists give it by oral. We put it right on the organ, including antihistamines, mast cell stabilizers, and we do our immunomodulation directly. And we use a wet vehicle, so we keep our organ moist. When you hear them talking about the antihistamines and the other options, once histamine gets loosed in the eye, we get all the symptoms, right? We get itching and tearing and edema. So that we can give it directly. Are we better off using those medicines directly in the eye or using it systemically? Or when do we know to do both?
Well, I think we can think that when there is only eyes affected, when there is only keratoconjunctivitis, I think really only the topical medication is interesting. But when it gets severe, I think to go both, systemic and topical is much better. But when we see that the allergy is all over the body, it's rhinoconjunctivitis, it's asthma, it's eczema. So we need to talk with allergists, with pediatricians also. And so we work together and to find out for the best treatment that we discuss. So I think there is no recipe, no complete recipe, but for sure, If there is other manifestation in the body, we need to go to a systemic treatment associated, of course, with topical treatment.
I think there are a few questions about cyclosporine. Maybe I could just ask the panel. So what is the concentration you start on? How frequently do you use it, the dosage? How long do you continue for? And do you find that the response to a particular type, is it different between palpable type versus limber versus mixed type for cyclosporine? These are the questions from the audience.
I may answer first, but I think that we have two options at the time. We have cyclosporine 0.1%, but the vehicle is very different. And we have also 1 or 2%. And it depends also on the medication. It could be BID, 3ID, or 4ID and QID. And for QID is for 0.1, and the other could be only twice a day. I mean, also for the duration, it's very difficult to say that, but at least it's 3 months. I never do less, and I try to cover the season, and I try also to stop during the winter when there is a seasonal form, but sometimes it's perennial form, and I just decrease the dose. I just decrease the how many times a day, and so I think it's very difficult to tell exactly the solution, and I think 2% is probably equivalent to 0.1 with the other formulation, but for sure it depends on children, and it's always difficult because in every country we have probably different presentation. That's why it's sometimes difficult.
Dr. Mora?
If I can add, I use cyclosporine for at least 6 months, and many of my patients use it for years. We live in Israel. Israel is a warm country, warm climate, Mediterranean, and you can't stop the medications. For sure, you can stop it during the summertime. Sometimes during the winter, you can give them once a day, once in 2 days, 1 drop, and that will be enough. But usually, I tell the patients that this is a long-term treatment, and be prepared to treat your child for years. And we see no side effects. So I usually switch to cyclosporine very fast. I see no use in giving steroids and going back to severe disease, giving steroids again. I usually start with cyclosporine, and this is very effective, and it keeps the patients very happy for years.
Fernanda?
Yes. Here in Argentina, there is only commercial 0.05% and 0.1%. The 1 and 2 preparation, you have to make a pharmaceutic. And in my experience, the 2% is very difficult that the patient tolerates. So I usually, in the complicated case, like the 1% and the one that came, I use the 1%. And in the one that they have less symptoms, the commercial one.
Okay.
Yeah, that's the problem. The stinging sensation with the cyclosporine, it's usually, the question is, what is the vehicle? And I'm fortunate to have a pharmacy that prepares it with a gel, which is not stinging at all, and this way patients can take it for years. But in the earlier days, I had to give the patient anesthetic before giving them a drop of anesthetic before giving them the drop of cyclosporine. This is how stinging it was.
Yes, originally it was oily. It was olive oil, so it was a big problem. And now the formulation is much better. But it was in the 1985 years, so it's really different today. And probably our formulation is quite well tolerated. But for sure, 0.1 is better, and with a new vehicle also, it's better also.
in Singapore, I tell them to put in the refrigerator, so they find it less stinging if they put it in the fridge and use it. Do you have the same experience? Yeah. And
yes.
Another question from the audience is, if you had to choose between topical tacrolimus and cyclosporine, what are your preferences?
Go ahead.
Okay, for us, it's quite easier to have cyclosporine because we can prescribe directly. And when we want to go to tacrolimus, we have to go to dermatologists. They are only doctors accredited to prescribe that. So we first begin by cyclosporine, and at least it's in all pharmacies, so that's quite easier. And we go to tacrolimus if there is a specific indication with lead eczema, or if it does not respond to cyclosporine.
Yeah,
so we're just one last question that's come up, and then we'll wrap up. For Bob and Elizabeth, how is immunotherapy done? Is it sublingual? Is it by injection? 30 seconds or less. Can you give us a very quick answer?
Elizabeth.
Okay, thank you. Well, basically, there's two ways to do it. Sublingual immunotherapy, where you, for 3 years, put a tablet underneath your tongue that dissolves, and it will give you local itching and local side effects, but it is a fairly easy treatment. You have to have a high adherence for the patient to do that. And then there's a subcutaneous. The patients with the lower adherence, you can do that. And some of the allergens can only be done with subcutaneous. And that is a trial where you start out weekly and updose over those first 15, 16 weeks, after which you can take a larger interval between the doses, and you have to continue this for 3 years as well. In Denmark, we have 6 weeks between the doses when we are in the end dose. Yes. So that's how
Excellent.
it's done.
That was perfect. Thank you. I want to just run through the answers to the questions we've asked the audience, the mentee questions. Forgive me as I look down at my phone to go through these. The first question we asked was, what part of the world are you from? A third from Europe, a quarter from Asia, a quarter from North America, about 15% from South America, and then the Middle East also. So a representation around the world. Fernando, we asked, what was the diagnosis for your case? And 2/3 of the audience said AKC. So in case you were wondering. We have a preponderance of female people, folks who identify as female, who are on our audience. We asked, what do you do? And the majority were pediatric ophthalmology and strabismus trained. We have some adult ophthalmologists and a few allergists that were out there too. About 10% were allergists. We asked, what is the treatment options, your first line treatment for a severe case of atopic keratoconjunctivitis in a child? Does the panel want to guess? The answer, the 2/3 of the people said steroids.
Oh, okay.
Topical corticosteroids. In treatment of VKC, when do you switch from steroids to cyclosporine? And the answer was, because I'm afraid of steroid dependence, not steroid consequences, but steroid dependence, which is interesting. Preferred treatment for VKC, completely evenly split between topical cyclosporine, topical multi-action anti-allergic drops with steroid treatment, and topical tacrolimus, a third. And we had around 3,000 people with us today, a little bit over that are answering here. In shield ulcers, what would you do? Yair, I think people listened to you because they said they would inject. And then for the last question, and I don't know if I'll be able to, if I can, I will very quickly, because the answer came up as something I want you all to see. And let's see if this works. Discussion was the best part. So people seem to very much like discussion amongst all of us as part of our discussion. So I want to just thank everyone as we wrap up. our final few slides that I will show. First, to thank our audience, because without you, there is no talk, and you are part of the discussion. Our incredible panelists, you were all wonderful, and this is difficult to do, to talk with expertise amongst various different specialists who overlap on the same problem. And thank you for all your time and effort. For Santen, for sponsoring us and letting us talk about whatever we wanted. They were very gracious and wonderful to work with. And Todd, as always, our hosts who put together these incredible sessions, allowing us to reach around the world. Our WSPOS administration team, Dara, and the fabulous Aquila, who make this all possible, without which we couldn't be here. Remember, we have these upcoming webinars that will still be going on, and these will also live live, recorded rather, on YouTube, where, for example, in our thyroid session, we had over 5,000 people watch after the live session, in addition to those that joined us live. Membership at the World Society of Pediatric Ophthalmology and Strabismus is free. The details are on wspos.org. Join the thousands of your colleagues worldwide who are members. Look for the Facebook page and group. Subscribe to the YouTube channel. It's really important so you don't miss any of the free content. Write me at my email, dgranite@UCSD, if you want to join the international listserv. If we've not met, please tell me where you live and where you've trained so I know. And with that, I want to just wrap up our meeting and bow in graciousness to all of our guests. Thank you for your expertise. Salway, thank you so much for moderating and help us plan out this group. Your efforts are incredible all along for the World Society. And for each of you, I thank you, and I hope you a good rest of the day for those of you who still have the day, and a good evening for those of you who are getting ready to go to sleep. Thank you again. We'll see you next time here on the WSPOS Worldwide Webinars.
Bye-bye.
Bye-bye.
Have a nice day. Bye.
Bye.
Bye all.